Good morning. In this presentation, I will first discuss about OCT. So we will discuss what is the technology behind it, how a normal OCT looks. We will learn about interpreting OCT and then see what are the roles of OCT in a daily retina clinic. Next, we will move to OCT angiography. We will again see what is the technology behind it. Then we will see how a normal OCT angio looks. We'll learn about interpreting OCT angiography, and there will be a word of caution at that stage. And then finally, we will try to answer the question whether OCT angiography can replace fundus fluorescein angiography. So let's begin with OCT, or optical coherence tomography. Now this OCT was introduced nearly 20 years ago. It's a non-invasive test which images the ocular structures in vivo. The technology or the principle behind OCT is low coherence interferometry. The scanning protocol or the scanning itself starts with a light source of a known wavelength. Next, this light is split into two beams. One of the beam goes to a reference target. The second goes inside the retina. The light is then reflected from these two targets. The light reflected from the known reference target and the nature of that light is fixed and known. But the nature of the light reflected from the retina is variable and unknown. We then compare these two beams by doing what we call interferometry, and we compare them for intensity and echo time delay. How do we scan the retina? So the light first passes through a single point, as can be seen here. So this laser has penetrated the retina vertically, and as it gets reflected back, we get the optical echo reflectivity of this particular point in the retina, and from that we create one single A scan. Now like this, the laser or the OCT machine keeps scanning the adjacent areas of the retina along a single line to create multiple A scans, and we combine all these A scans to create a two-dimensional B scan. And you can see here, this is the reflectance image of the retina, and you can see this green line. So this green line is the line which is represented by this B scan. So as you can make out that the machine would have scanned multiple points along this green line to create this single B scan. Now by repeating the B scan at adjacent lines, we can create a three-dimensional volume scan. So as we can see here, you see this B scan itself is moving. As we keep moving from the bottom to the top, you can see the corresponding B scans are changing. Now if you take all these B scans, then the machine can then create for you a three-dimensional map or volume scan rather, like this for you. So this is how a normal OCT looks. Let us try to label this normal OCT. So if we zoom into the upper part of the image, so the first thing we see is formed vitreous. Next we have the posterior cortical vitreous, the pre-retinal space, the retinal nerve fiber layer. Next to it, the ganglion cell layer, which is slightly hyporeflective. Next, the hyperreflective inner plexiform layer. The inner plexiform layer is abbreviated as IPL. So it is very easy to remember that everything starts with the IPL. So you can just remember like that. So the inner plexiform layer is followed by this hyporeflective zone, which is the inner nuclear layer. Then there is again another hyper-reflective zone or white type of zone, that is the outer plexiform layer. And then there is a broad darkish zone or hyporeflective zone which is divided into two. The top part is called the Henle's layer and the bottom part is called the outer nuclear layer. So IPL followed by INL followed by OPL followed by ONL, and it all starts with the IPL. That is how you can remember. Now if we look at the lower part of the image, So we see some hyper reflective bands. The thin band which we see at the top is the external limiting membrane. It is followed by a dark zone called the myoid zone. Then a thick hyper reflective white band, that is the ellipsoid zone. Next again a dark zone, that is the photoreceptor outer segment zone. And then we have a very thick white line which is split into two. The upper part of this white line is what we call the interdigitation zone, where the photoreceptors are basically locking in with the retinal pigment epithelial cells. And the lower part is a complex of RPE and Bruch's membrane. Normally you cannot separate between the two. In certain pathological conditions we can separate between the RPE and the Bruch's membrane. Below the Bruch's membrane is incidentally part of the choroid. So below it is the choriocapillaries, which is followed by the intermediate sized choroidal vessels, the sacral layer, the large choroidal vessels, the halar layer, and finally the choroidoscleral junction. So what are the scanning protocols for retina using an OCT? So you can just scan in a particular area of interest by doing few line scans there. Now this scanning of putting these lines one adjacent to the other. This is what we call the raster scanning protocol. So here you are just scanning a particular area that you are of interest. If you quickly want to scan the whole of the macula, instead of the line scan, you can use this radial scan. The only problem is that the radial scan, if you see, it is scanned this area, it has scanned this area, but the in between area has not been scanned. So in between two radial scans, the retina that is there in between two radial scan, we really don't know what is happening to that part. So why do we then do this? So previously when the machines were slow, we used to do a lot of radial scans to ensure that we can do some scanning before the eye is moved or patient starts blinking or becomes uncomfortable. Nowadays we have very fast machines, so we rarely advise a radial scan unless the patient is say a very young child or having nystagmus or a very uncooperative patient. Then to just do a screening you can do a radial scan, but the trouble is that you will have data from this line, you will have data from this line, but the retina which lies between the two adjacent radial scans, you really don't know what is going on there. The machine just makes up that part. So what this protocol that we usually use in our clinics is the macular cube scan, which is a cube. This can be a 3 by 3 millimeter cube or a 6 by 6 millimeter cube or even wider. So this is a scan where we are just going to scan every point within this cube. So that allows us a lot, that provides us a lot of data. So this data can then be represented as a 2D scan or a 2D line scan. You can see the reflectance image which is clearly showing that this particular 2D scan belongs to this line, and the machine has already scanned all the areas here using a macular cube protocol. Or if you want, you can use all these B scans to generate a 3D volume scan like this, or the data can be represented as macular maps. So this can be color coded topographical map or a numerical data map. Let us now see how we interpret OCT. So when you get a report, OCT report, you will get something like this. So there will be three parts. There will be a B scan, a line scan. There will be a topographical color coded map like this. And then there will be the numerical data map. You are supposed to see carefully all three. If in case you can't see the whole scan because the machine is not close to you, you may have referred the patient for OCT somewhere and the patient may come back with a report. Look at all these three parts. So what can we learn by just looking at the B scan? So by just looking at the B scan without doing any further critical analysis, you can make out whether the retina is attached or detached, whether there is swelling of the retina or whether the retina is thinned out like this. You can make out whether there is any dark abnormal space like this, which is an hyporeflective lesion, or there is a bright abnormal lesion like this, which is a hyperreflective lesion. You can also make out if there is a dark shadow effect like this, where you can see something very bright and then there is a dark tail, following that thing. This is called shadowing. Or there is, same shadowed like effect, but this time it is all bright shadows. It's not dark shadows, but bright shadow, which we call as reverse shadowing. So you can make out all these changes just by looking at the B scan. But you are also supposed to look or assess the B scan layer by layer. And usually it is done from the top to the bottom. So you first see whether there is normal vitreoretinal interface or not. So this is how a normal vitreoretinal interface appears. So what are the changes you may see there? Well, there may be a vitreoretinal separation. So you can see here that the vitreous is separated from the retina, or PVD is there, or there may be an abnormal vitreoretinal separation with some persistent attachment near the fovea causing vitreofoveal traction, or there may be anomalous vitreoretinal relationship. So there may not be, you may not be able to see the posterior highlight, but you may see a thick membrane lying on the retina and distorting the retina. So this is what we call as epiretinal membrane. Next, look at the foveal contour. So this is how the normal foveal contour looks. Now here again, you may have a break in the foveal contour like this. So this is a macular hole, a full thickness macular hole. Or there may be a partial distortion of the fovea with some splitting of the retina. This is a partial thickness macular hole or lamellar hole. Or there may not be any hole, but just that the foveal contour is very steep, which is due to the epiretinal membrane contracting the fovea centripetally. And this is called a pseudomacular hole. Next, you look at the inner retina. So the inner retina is up to this white line. So all this is inner retina. And you try to see if you can see these sandwich-like structures. So the two common findings or abnormal findings you may see here are, there may be some whitening in the middle of the retina. This is called paracentral acute middle maculopathy, found in ischemic conditions like central retinal artery occlusion, BRAO, CRVO or BRVO. So this suggests that there is inner retinal ischemia. Or you may find something like this, where you can see clearly that the retinal layers are intact on this side, but you can see the retinal layers are intact on this side, but you cannot see the retinal layers at all here. You see this very beautiful comparison. So this is what we call disorganized retinal inner layers or drill, which is an important biomarker in medical retina. Then you look at the outer retina, and usually the outer retina starts from this dark zone and then there are these bands. So you look at them carefully and you try to see if that dark zone in the outer retina is swollen up. As you can see here, this is a case of intraretinal fluid, or if the sensory retina is completely separated from the retinal pigment epithelium, as you can see here, due to subretinal fluid, or the bands that we were talking about, whether those bands are discontinuous, as you can see here. So this is what we call disruption of the ellipsoid zone with or without disruption of the external limiting membrane. And if these bands are disrupted, as is seen here, that can have a serious impact on the visual prognosis. Finally, you look at the RPE choroid complex. This is how it normally looks. Now you can get small bumps, separating the RPE from the Brooks membrane. These are drusen's. Or you may have large, the satellars layer, enlargement or engorgement of the satellar layers with thinning of the choriocapillary layer, capillary layer. This is pachychoroid. Or you may have separation between the pigment, large separation between the RPE and Brooks with an hyporeflective space in between. This is a serous PED. Or there may be again separation, a large separation between the RPE and the Brooks, but there may be hyperreflective structures in the inside, which suggests a fibrovascular PED. Next, you look at the macular map. The macular map, what do you see there? So it normally looks like this, but there may be some red areas, red or white areas, which suggest thickening in those zones, or there may be increased blue areas in the center or in the periphery, usually in the center, which suggests atrophy. Now, this macular map is extremely helpful in counseling the patient as well as in follow-up, because you can see how your treatment is affecting the macular thickness. So, for example, this is again the case of a pseudo macular hole with an epiretinal membrane. You do the epiretinal membrane peeling surgery, and this is 15 days later, and you can see already that these red areas are now slowly turning yellow and green. That means the thickening is going down, and this is after 2-3 months from the surgery, and you can now clearly 3 months from the surgery rather, you can clearly see this red area has now converted into totally into yellow. So we know that this thickening has gone down. You can see this white area has also now turned red, so this area has also become less thick. So by following this map, we can clearly easily make out how the retinal edema is going down with our treatment, and the patient definitely should improve or experience some improvement in vision. So what is the role of OCT in clinics? And the answer to that, it is an essential part of our retina clinics now, because it helps at every stage. It helps in diagnosis. For example, now is this a case of macular edema? The answer is no. It is a case of retinoschisis. You can see this splitting in the outer retinal layer, in the outer nuclear layer, which is extending right up to the disc, and extending well beyond the fovea on both sides. So this is retinoschisis. This is not a normal intraretinal fluid, because there in intraretinal fluid, the fluid will be limited more or less around the fovea. So such a diagnosis can be so easily made just by OCT. Second, it is important in planning treatment. Now, OCT is very crucial to say planning treatment in cases like epiretinal membrane, macular hole, wet AMD. But I will just explain how we apply OCT knowledge or knowledge gained from OCT in managing DME patients. Because probably diabetic macular edema is one of the commonest medical retina conditions we all face day to day. So if we have two diabetic macular edema patients like this, and you can see their macular maps and the B scan. So, and if we have to decide which one do we inject, and do we inject in both cases, or what do we do? So the entire decision is based on OCT, because the image on the top, this image is of a non-center involving DME. You see the central foveal grid, if you see in the grid, the central foveal zone is unaffected by the edema. So here laser is the gold standard. But in the picture below, there is a severe thickening in the center. So this is center involving DME, and we now know that the laser is not preferred treatment here. We should start initiating treatment with injections. But then the question may come that which injection? Do we start treatment with an anti-VEGF or a steroid? Again, let us take two cases. Both are DME patients, and these B scans can be compared. So the image on the top is of a case which is a relatively fresh DME. You can see some amount of intraretinal fluid and subretinal fluid. Here, starting treatment with anti-VEGF seems quite correct. But if you look at the DME B scan of the DME patient in the below, you can see large cystic changes. So much of hyper-reflective foci, all these white dots, these are called hyper-reflective dots. This is highly suggestive of a chronic DME with probably inflammation playing an important role. It makes sense, therefore, to initiate treatment in such cases with DEX implant. So OCT biomarkers can help you plan treatment in DME. So that is how OCT is used in day-to-day clinics. Let's now go to OCT angiography. So OCT angiography again was introduced nearly 10 years ago. It's a non-invasive test, and it images the retinal blood vessels in vivo. So this is a multicolor image of a diabetic patient, and these are the OCTA or OCT-angio images from the same patient. These are the en-face view of the OCT angiography of this patient. So again, how do we do OCT angiography? So OCT angiography is a functional extension of OCT, and it is achieved by repeating the B scan at a particular location again and again. So I told you that by repeating the B scan at adjacent locations, we can create a macular cube, or we can create a macular cube or a volume scan or a three-dimensional picture. But if instead of scanning adjacent line, you scan the same area again and again, that is how you can create a OCT angiography image. Now, how so? Because every time you scan the same area, then you compare the two scans for any change. And this is what we call decorrelation. So you have scanned the same area 7-8 times, and then you are comparing those 7-8 scans, and you are seeing whether there has been any change. If there is any change, that is what we call motion contrast, then the only reason or logical explanation for that change is that something must have moved. And what can move inside retina? Everything is fixed except for the blood cells. So the blood cells or red blood cells are the only thing which is moving. So if there is any motion contrast between 7-8 scans that you are taking at the same location, then they must be representing the blood area, the areas of vascularity. So that is exactly what happens. So this is, say, a retina. You can see this. So this is a retina, and now I am going to scan this particular line, and we scan it and we get a scan like this. Now I repeat this scan multiple times, and then we compare those 7-8 scans at the same line. When we do that, what we get is a flow map like this. So you see all these yellow dots. So if you see all these yellow dots, these are the points where the machine, after doing the scan again and again at the same location, these are the points where the machine found there was some change. And therefore, it is considering all these points to represent red blood cells or moving blood. So then you overlap this scan to the structural OCT, and that is how you get a octa flow map, octa OCT angiography flow map on the structural OCT. Now there are a few interesting thoughts which we must consider when we have discussed this point. The first interesting thought is, if we are scanning the same area again and again and looking for change, we can actually miss this change. How? Say the blood flows very fast, even faster than the interscan interval. So you have scanned once, now you want to scan again. In between the two scan, if the blood has already moved out because it was so fast, then you may not see any change because everything has already moved out. Or if the blood is moving too slow, so you have scanned once, you have scanned again, the blood is not moving. It will move, but before that your scanning of that area is over. Because as I said, you have to scan every area. So you scan one area 7-8 times, then you move to the next adjacent area. Now by the time you have scanned that area 7-8 times, if the blood has not changed, then you will not know that there is a change happening there because your scanning speed was so fast. So that means even if there is some movement happening, if the movement is very fast or very slow, the OCT angiography machine can miss that. Second, and this is also a very interesting thought, what are we seeing? We are not, say for example, if you saw the images I showed, and I will show few more images, we are showing blood vessels. But the blood vessel wall is not moving. It is a static structure. So what we are representing as blood vessel is actually column of red blood cells inside the blood vessel. So it is the vessel lumen that you are seeing, not the blood vessel itself. And the third interesting point is that if there is any movement, the machine will consider this as blood flow. Even though there may not be blood, but there may be movement due to some other reason. And that is why OCT angiography is a highly sensitive system, and it is also very prone to artifacts. And that is why OCT angiography, when we are interpreting, we have to take some cautions, which I will come to next. So let us first see how a normal OCT angio looks. And before we go there, let us quickly revise how a normal retina, what is how is the organization of the blood vessels in normal retina. So the inner two-third of the retina is supplied by retinal blood vessels, and this is up to the outer border of inner nuclear layer. So you see this. So inner nuclear layer is this layer, and this is where the retinal blood vessels stop. So from outer plexiform layer on downwards, you don't have supply from the retinal blood vessels. So in this small area from the retinal nerve fiber layer to the inner nuclear layer, there are four parallel capillary plexuses. These are first the nerve fiber layer capillary plexus, which is along the RNFL. Then the superficial capillary plexus, which is along the ganglion cell layer up to the IPL or inner plexiform layer. Next, we have the intermediate capillary plexus, which lies along the inner border of the inner nuclear layer. And finally, the deep capillary plexus, which is along the outer border of the inner nuclear layer. And then comes, of course, the lower or outer one-third of the retina, which starts from the outer plexiform layer. And this is supplied by the choroidal blood vessels. So this is the avascular zone, or we also call it the avascular complex, AVC. So if you look at the retina, in a B scan of the retina, this is how the B scan looks. Now if we see the octa image, in octa you will get this structural OCT, the structural B scan, and then you will get an adjacent image like this, which is a composite of the structural OCT B scan with the flow overlay. So all these yellow dots are the places where the OCT angiography machine has detected flow. So this is an OCT angiography image where we have the structural OCT with the flow overlay image. But probably this is very, this image when we see it is very difficult to really appreciate the blood vessels, how they are distributed, because we are not habituated to seeing a B scan and imagining how the blood vessels are distributed. So the actual view which we are habituated to see is what we call the en-face view. The en-face view is very much like the image that we see on FFA. So there you have this beautiful view of the superficial vascular complex, which is the normal, this is a normal image of the superficial vascular complex. The superficial vascular complex is the complex, it has two parts, the retinal nerve fiber layer plexus and the plexus in the ganglion cell layer up to the inner border of the inner nuclear layer, that is, up to the inner plexiform layer, the ganglion cell layer and the IPL layer, that is the superficial vascular plexus. So these two plexuses form the superficial vascular complex. Next we have the deep vascular complex, which is again made of the intermediate capillary plexus and the deep capillary plexus. So intermediate capillary plexus is in the inner border of the inner nuclear layer and the deep capillary plexus in the outer border of the inner nuclear layer. So you have the superficial vascular complex, which is up to the IPL. Then in the INL or inner nuclear layer, you have the deep vascular complex, and then below that you have the avascular complex, which is from the outer plexiform layer to the RPE. Below that, of course, you have the choriocapillaries, which are not so easy to see with SD OCT. You can see them better with a swept source OCT angiography. But they look granular on normal SD OCT angiography machine. And you have the choroid, which is below the choriocapillaries. These are the halar and the sacral layer. The interesting thing is these dark spaces actually represent to the large choroidal vessels. Now, why do a blood vessel appear dark? Exactly because of a reason I told before, that when the blood moves too fast, then the OCT angiography may not be able to detect anything because the blood has moved so fast, and that's why this may look like no change is there and they may appear to be dark, as you can see here. So in the choroid, these dark spaces are the ones where you are actually having the blood flow. So then how do we interpret OCT angiography? So this is a very important point. First, you have to rule out artifacts because it is very common in OCT angiography. For example, in this patient of CRVO, if you look at those pictures, you see there is something dark here, as if the blood vessels are gone. There is an infarct. In the deep vascular plexus also, there looks like an infarct. And in the avascular plexus, you can look as if there is some new blood vessels, because you don't expect any blood vessel in the avascular complex. So what is happening here? Now we go back and review the structural OCT with the OCT overflow picture or the B scan, and you can see completely that there is wrong segmentation happening. The machine, because of the edema, is unable to find out exactly where is the IPL or inner plexiform layer, and therefore it is just messing up big time. This is called segmentation error. It is very common in very edematous or very atrophic retina, and therefore you should always check the B scan along with the on-face image to see if there is some segmentation error happening. So here is another patient. You see some very funny looking blood vessels here, some double blood vessel. What is happening here? So now you go back and first you check the multicolor image, and you see the multicolor image is not showing anything like that. It is all a normal looking fundus. So now you understand that this is what we call a motion artifact, and this is further confirmed because in the deep vascular complex you see all these black areas because everything has moved and the machine has not been able to do the scan properly. So do rule out all these artifacts before you start interpreting the OCT angiography. So next, when you try to interpret OCT angiography, do not depend on one view. So there are two views, the B scan and the on-face view. You have to always see both views. For example, in this patient, this is a patient of a macular BRVO with a long-standing chronic cystoid macular edema. You look at the B scan, and you can clearly see there are cystic changes, and you may think that okay, let me go and inject. But when you look at the on-face image of the deep vascular complex, you see this large distortion of the foveal avascular zone with capillary dropout. So this tells you that there is macular ischemia, and now you must talk to the patient and counsel him separately and not consider him or her for just as an ordinary case of macular edema. Similarly, this is another young patient. You see this multicolor imaging is showing some suspected, some serous detachment or something here going on here. So you do OCT angiography and it shows a beautiful classic neovascular membrane. So if there is a CNVM, should we just go ahead and inject? Here you look at the structural OCT and you see there is no SRF or no fluid, no subretinal fluid, no interretinal fluid, just this fibrovascular PED which corresponds to this capillary, which corresponds to this classic type 2 membrane, type 2 CNVM. So this is what we call a non-exudative CNVMs, which are now commonly diagnosed with OCTA. So there is actually no trial which shows that we should treat non-exudative CNVM. Surely we must monitor these patients carefully, because if they start leaking, then we definitely treat. But if based on this on-face image alone, if we require decision to treat, that would be wrong. So always look at the on-face image along with the B-scan image. So the benefits of OCTA is that it is non-invasive, there is no dye involved, it is fast, it allows us to see both the tissue structure and the blood flow, and it provides a 3D resolved microvascular resolution of all vascular plexuses, unlike FFA, which actually basically shows only the superficial vascular plexuses. So for example, here is a patient, a 52-year-old male who had a past history of 3 episodes of central serous chorioretinopathy, and he comes back with complaint of diminution of vision in the right eye since 4 months. Now you can see there is some subretinal fluid with these bumps, so you wonder what is going on, and you do OCT FFA, and you see in FFA there is a stippled hyperfluorescence. You really don't know from where the leak is happening, and you consider whether it is a chronic CSC, should I do PDT, what should I do? Now you do a OCTA in this case, and it clearly shows a large CNVM has developed in that area. So this is a CNVM in the setting of chronic CSCR. So now you know that we need to do anti-VEGF. But then can OCTA replace fluorescein angiography altogether? For that, let's see first let's see what are the benefits of fluorescein angiography. So fluorescein angiography shows dynamic time resolved information like leak, stain, pulling and all this. It also helps us to study the vessels up to the periphery. Now with swept source OCT angiography, you can actually do large wide scans of 12 millimeter by 12 millimeter also. But you can't do them with the spectral SD OCTs or SD OCT angiographies. Why? Because you need to be very fast to do a wide angle octa, because if there is even a little slowing, there will be a lot of artifacts. But then swept source octa machine is not really easy to afford, and that's why it is still not commercially widely available. So for us, basically octa is for the macular vessels, and FFA can help us study the peripheral vessels. Now this is important because, for example, in this case of a diabetic, who has already got multiple injections and has been suggested more. So you do a structural OCT and octa and you see this, okay, there is some fluid, there is no macular ischemia, and you may feel, okay, let me go ahead and inject. But if you do a fluorescein angiography, you then realize, oh my God, this is a case with a lot of capillary non-perfusion and early new vessels. Probably that's why the edema is not going away easily. And I need to do not only injection for the DME, but probably I should also consider doing a PRP to reduce the load of the VEGF. So then someone can say that if we are involved or if we are interested only in a macular pathology, then what about that? So if in a macular pathology, if we are not really interested about a peripheral disease, probably octa should be good enough compared to good enough to replace fluorescein angiography, right? Well, not exactly. So let's see one such case. Again, we are sticking to a case of a diabetic retinopathy only. So here is a patient who has a moderate grade NPDR with diabetic macular edema, which we can clearly make out with the help of this macular map, which is showing this heat here, and you can see the P scan, which is showing this fluid. But as we have already studied, this is a case, again you can see there is no center involving edema, so it is a non-center involving CSME or non-center involving DME. So we know that for non-center involving DME, laser remains the treatment of choice. Now how do you do laser? You will do laser by finding the leaking microaneurysms and doing laser at them. So if we look at the octa image of this patient, you see this is the superficial vascular plexus and this is the deep vascular plexus. The aneurysms are not that clear, and even if you see some capillary dropout and you can see some widening of the intercapillary space, it's very difficult for us to know what has exactly caused this thickening here, which is what is the source of the leak. But if you look at the FFA image, now you can clearly see this is the early FFA image and this is the late FFA image, and you can just have a look and yes, these are the aneurysms which are causing this leak. They are also corresponding to the area of thickening. So if I do a focal laser in this area, though it is in the papillomacular bundle, so that is again another controversy, but if we have to do laser, we should target only these leaking microaneurysms. So even in a macular pathology, you cannot just replace the FFA with octa in all situations. So to conclude, OCT was introduced 2 decades ago and it has become an essential test in ophthalmology, and it really helps at all levels of management, diagnosis, prognosis and therapy. OCT angiography, which was introduced 1 decade ago, has also grown in importance in ophthalmology, and though it can definitely replace FFA in many situations, I don't think it is right to say that it can completely replace fluorescein angiography in our practice. So thank you so much for this patient hearing, and I'm sorry for overrunning my time. Thank you.